in the field of health. He has held numerous leadership roles in health sector of Ethiopia, including serving as a health minister of the Ministry of Health for about 13 years, and a senior advisor to the minister for about 5 years. In his roles, he led the health sector, mobilized health resources, set policies and implementation strategies, and oversaw key health sector mission at national and subnational level. He emphasized the importance of evidence-based practice and was involved in utilizing evidence to inform healthy policy making. His leadership has contributed significantly to the development of health sector in Ethiopia. So Dr. Kabede will talk on building and leading public health system in resource limited setting, and he would share us his experience in this regard. So thank you, Dr. Kabede, for accepting our invitation to be a panelist on this topic, and I cordially invite to come to the podium. Okay, our next panelist is from overseas, from Harvard, Professor Peter Berman. He is a health economist with 40 years of experience in research, policy analysis and development, and training. By training, he's a global health expert. Professor Berman is a professor at the School of Population and Public Health at the University of British Columbia in Vancouver, Canada, and he is an adjunct professor in global health at Harvard. Professor Berman's specific areas of work include analysis of health system performance, the design of reform strategies, assessment of supply side of the healthcare delivery, and the role of private healthcare provision in health system and development in health system. He pioneered developing and using national health account as a policy and a planning tool in developing country. And Professor Berman has worked extensively on health system in various developing countries, including Ethiopia. So today, Professor Peter will be taking on or talking on developing strategies in improving health care service, focusing on healthcare financing, his lived experience. So thank you for accepting our invitation to be a panelist, and he will be joining us from online. So we checked and he's online waiting us. Thank you once again. The third panelist will be Obse Lubo, born and raised, sister Obse Lubo, born and raised in the city of Najo, Oromia, region Ethiopia. And in 2009, only 2 years into her career as a nurse, Obse began organizing annual medical mission trip to Najo Hospital with a group of nurses and doctors from Northern California. Every year since then, Obse has traveled to Najo and other parts of Oromia to work with locals in capacity building, resettlement supporting, and building houses for internally displaced people. And in 2012, she founded a non-profit organization called East African Medical Association, a federal foundation, to establish a quality and a sustainable medical network that is responsive to the need of underserved, vulnerable, and unreachable population. So in September 2020, through matching grant from Rotary International, she installed the first oxygen plant in Najo, which is serving the Najo Hospital and the surrounding health facilities in Oromia and as well in Benishangul Gumuz. Currently, she is an international advisory board for Global Healthcare Foundation and founding member of the International Oromo Health Professional Association. She's a proud nurse, an advocate for the patient, and is a registered nurse at Stanford University Medical California. She will be talking on the role of philanthropies in building healthcare system. And thank you again, Sister Rose, for accepting our invitation, and again should join us from online. Yes. The next speaker will be Dr. Balaine Elta. By profession, he is an MD and specialized in pediatrics and child health, and he has experiences as a medical doctor of Shashamane Hospital, clinical vice provost of Adama Hospital and Medical College, and pediatric department consultant in head at Ambo University, and he worked as an assistant professor at Hawassa University. Currently, he is the chief executive director of Negale RC General Hospital and the Medical College, and also president of Oromia Physician Association, and his special inclination is humanitarian and health advocate. Dr. Balaine will be talking on health professional roles in achieving healthcare quality and equity. Thank you again for accepting our invitation. Dr. Balaine, welcome to the podium. So the next panelist will be Dr. Maleda Tafarra. Dr. Maleda is an assistant professor at Haramaya University, and she has 16 years of work experience at various levels in the healthcare system. She started her journey from diploma, serving at lowest healthcare system levels, and through that, she obtained her BSc from Addis Ababa University in comprehensive nursing, in comprehensive nursing, and recently finished her PhD in nursing, focusing on the midwifery. Maleda has been involved in various academic research and community service activities, and has published as an author, first author, and co-author of more than 15 publications. She is currently an editorial manager of the East African Medical Journal and a PhD coordinator at Haramaya University. She has been serving as an advisory council for different research councils at the ministry and as well at Haramaya University. She is currently the president of Ethiopian Nursing Association, and her talk will be on leadership and women in healthcare system. So thank you again for accepting our invitation, and you are welcome to the podium, Dr. Maleda. The next panelist will be Dr. Godana Jarso Guto. He obtained his MSc in cardiovascular medicine from the University of South Wales, and he has several diplomas and certificates, and his specialty certificate is in internal medicine from Addis Ababa University, and his medical doctor is from University of Gondar. He has more than 17 years work experience, starting from down in the rural area. So he served as a general practitioner, medical director, emergency surgery physician at the Negale Borana Hospital. He served at Oromia Regional State as head of HIV program department and coordinated a lot of activities. He was the founding provost of the Adama Hospital Medical College, serving at different capacities. Now he is the founder and general manager of the Dire General Hospital, and he has several experience at national and regional level health system activities. He's a member of more than 5 associations from in country and abroad, and has published more than 16 publications. Dr. Godana will be talking on building public-private partnership to meet the highest need of the highest public needs, and he also will talk on what are the bottlenecks around that. Again, thank you for accepting our invitation. Dr. Godana, welcome to the podium. So, as we have been doing, we'll be strict on time. You will be given 5 minutes for the sake of time issue we have. So first, I will start from Dr. Kabede Werku, just to talk or to tell us his experience in building and leading public health system, especially in a very resource-limited setting. So he has very extensive experience there, and I'll give 5 minutes, and it's your time, Dr. Kabede.
Thank you very much for this, for extending this invitation to me to share my experience in the health sector. I will talk on from when I joined the ministry as a state minister in October 2005. I served there for 13 years, and it was a fortune time, and it was the beginning of the implementation of Health Sector Development Program 3. And there were challenges in every aspect of the health system, critical shortage of human resource, unfair and even distribution of professionals in the health infrastructure, and also low uptake of services. And this is witnessed by different surveys, assessments, and others. So in this regard, we, as a ministry and as a leader, we took bold decisions, particularly in relation to human resource development and the infrastructure enhancement. At the time, in 2005 or to 1998 Ethiopian calendar, number of health centers were not more than 600. Number of hospitals were not more than 131 or so. And the health officers were around 600. And medical doctors were not more than 2,500. And the medical schools were 3. Of course, Mekelle and Hawassa University started enrolling medical students, and the annual output of these medical schools, including medical health science colleges, were not sufficient to deploy professionals to the health system. So we formed a council with the Ministry of Education on medical and health sciences education curriculum council, and we harmonized the curricula, and we lifted the year of education for allied sciences and from 3 to 4, and also harmonized medical education and other curricula. And we took decisions like to at least equip or staff one health center by one health officer, and Warada health offices to be led by one health officer. So the target was to produce around 4,000 health officers, and we were able to produce more than that. And now the number of health officers is around 17,000. And concomitantly, we have also increased number of medical schools from 3 or 5 to now around 27, including those hospitals which were affiliated for the Accredited Health Officer Training Program, like Adama, Debre Abraham, and others, now serving, including Goba, Nakamte, now serving as medical schools themselves. So we laid a foundation by that. And in relation to the infrastructure expansion, the most important undertaking was to have a partnership with our development partners as well as with the regional states, and convincing our partners. You see, there was era of huge investment for health programs, particularly HIV, TB, and the malaria, particularly of HIV. It was not possible to provide HIV services without human resource, without health facility. So we convinced even the American, US, the American Congress to provide some amount for the construction of health centers, the renovation of facilities. Some of the facilities that you are working in are exemplaries, like in Jimma University, Nakamte Laboratory, Adama Laboratory, Adama OPD Annex, and Shashamene OPD Annex. This can be taken as a result of partnership. On top of that, Ministry of Health has developed a special partnership from, it was a progressive partnership development. At the beginning of the Health Sector Development Program 3 implementation period, Ministry of Health, along with 13 development partners, signed Code of Conduct for harmonization and alignment of efforts. And at the end of the year, beginning of 1999 Ethiopian calendar, we assessed, and adherence to that Code of Conduct was loose. Then we developed Health Harmonization Manual. As we developed the Health Harmonization Manual, there was a move globally of International Health Partnership Compact, which Ethiopia was a signatory at global level. And following that, we developed our national International Health Partnership Compact, followed by joint financing arrangement, which led for the establishment of the MDG, now the SCDG Performance Fund, which we are using for soft programs, particularly which is supporting, including some infrastructure development, mostly for the human resource development. Not now, this can be also seen as a good start. Of course, in our health system is not strong enough, and there are improvements which you witness, which you have also deliberated on, including the training, accelerated training of midwives, health officers, health extension workers, expansion of the health center from 600, now it is close to 4,000 at national level. The number of hospitals is around 400. And in terms of equity, it is addressed. But I heard this morning in relation to efficiency of services in some aspects. That is what we need to look into, because the access, number of professionals, number of health facilities, and also the current surge of malaria can be seen seriously, including high neonatal deaths, which constitute more than 40-something% of under 5 mortality. So the investments need to provide the services that our community needs. In Ethiopian health system, we know we shall not point fingers to the sector. Health system in general, particularly public health system, is a reflection of our economy. So our economy is doing good, but we are poor in terms of national economy, dollar amount. So we have to take that seriously. and as attributes, leader has to prioritize and work to the end goal. And in the ministry, we see partnership and as a leader beyond the facility. So it is a sum of all components that add up to bring the intended goals. And the ministry with the regional health bureaus, we are aligned. We work as a one, not as a federal state, but as one entity that serves the public. The remaining challenges include the recurrent droughts and the related health, nutrition, and hygiene related health problems. Sustaining community engagement, use of aptex, including malaria, HIV, and neonatal services. And so that is efficiency of use of the investments that we have made need to be seen. The healthcare financing is still a serious challenge. More than 1/3 of our the total health expenditure is from out of pocket, and the 1/3 is from external world. But we have to work on that line, and the Oromia regional government is doing very well in terms of enrolling to the community-based health insurance, but delayed initiation of the social health insurance is still a challenge, so that we cannot harmonize and unify one pair mechanism. And the health leadership and the governance needs to also be seen. See, some districts, some zones are excellent, even within the same region. So the difference there is not the difference of some certainties, but it is reflection of the leadership and the governance at local level, particularly Warada level. The number of health workers. You see, we are now graduating many doctors, many health officers, nurses, and other professionals. But because of the narrow physical space, we cannot deploy and recruit them to the needy to the needy community. So we need to work on that line as well, particularly related to the availability of drugs and the supplies. This is also a reflection of the shortage of budgets at local level. The good thing that Oromia government is doing is it procures the medicines, equipment, and supplies for the health centers at central level. But that may not suffice the service delivery at local level, and the expansion of the community pharmacy is good, but the allocation of budget need to be uplifted. So if I go on talking, I would go on talking, but I need to quit here. Thank you very much.
Thank you, Dr. Kabede, for the brief highlight of your over 20 years journey, and I think there are a lot to learn from how we came through this journey in terms of our health system. It has been over a century, and when we see the recent development, I think we can learn how much people were committed in just bringing up all the resources they have in order to cope up with a limited number of trained people, the limited resource, and as well limited healthy facilities. So I'm sure a lot of questions will come, and I will not take much time here. So with this, we'll move on to Professor Peter online. Can you? So Peter, can you hear me?
I hear you, yes. Can you hear me?
Yes, perfectly. So it's your time. Okay. You have 5 to 6 minutes just to summarize about your topic of talk. Thank you.
Thank you very much. And thank you for the kind invitation to join you this afternoon. I regret that I can't be with you in person right now, but nice to hear Dr. Kibede. I haven't met him for quite some time. I wish you well, sir. So just to give some reflections on the role of healthcare financing in improving healthcare delivery. I think it's critical to start with being clear about the goals of our efforts in improving healthcare delivery. And really, we think about this in terms of three concurrent goals. We want to get people who need services to receive those services. We want to make sure the services they receive are of good quality. And then because resources are limited, we want to make sure that we don't waste resources, that we try to keep systems efficient. And it's important to keep in mind in trying to achieve these goals, there's a very important element of equity. We want to make sure that the people who are the most vulnerable or least able to take part in the service delivery, that they are able to receive these services of good quality. And this is very important to keep in mind in Ethiopia because of the great disparities in ability to get these services. Now, just to give a bit of a framework from a more academic perspective on healthcare financing, we like to think of healthcare financing consisting of three very important tasks. And of course, I don't need to remind you, and Dr. Kibede has reminded us about the importance of financing, of the importance of financial resources in a healthcare system in a country like Ethiopia. So we think of healthcare financing as involving raising money. We call it resource mobilization, but it's not always just money. It's also other things that are contributed in kind. We think of the challenge of pooling those resources into an entity and a mechanism where that money can be targeted and used. And then we think of the ways in which money is used to pay for services, call that payment and purchasing. So in Ethiopia, there are significant challenges in all three of these areas, and I just want to enumerate some of the biggest ones. In the resource mobilization area, Ethiopia still receives money for its healthcare system from a wide variety of sources, including external sources. And these include contributions in financial terms, in money, but also contributions in kind, in goods and other kinds of physical resources. Now, Ethiopia has really made tremendous progress in several decades in increasing its resources for healthcare, and that's really to be complimented. But still, and as Dr. Kibede reminded us, those resources are still quite limited in relation to the needs. But when these different sources of funding come into the system, they come in through different channels at the federal level, at the regional level, and even at the Warada level, because Ethiopia still relies significantly on the users to pay for services. And these different channels create a complex situation for managers. So even at the regional level, it isn't always clear how much is coming from all these different channels and when it is coming in order to have a better ability to plan the use of these resources. And not all the decisions about those resources are made at the regional level. So I think this is and as we have been working with Oromia in the last few years, one of the interesting tools we've been developing with you is these regional level health accounts, which is a way to calculate the different sources of funds at the regional level and where they come from and the channels that they flow through. Unfortunately, still, it is difficult to do that in a very timely way. Sometimes this information is delayed by several years in terms of being able to compile it, which doesn't make it especially useful for forward planning but at least it is very useful for knowing what is there in the system. In the area of pooling, there are also complexities. In Ethiopia, you have now been developing the community-based health insurance system, and as Dr. Kebede mentioned, also social health insurance. And this sits alongside the standard government channels of funding using the government financial management systems. So these are, again, separate channels for pooling funds. And one of the things that has to happen in the pooling process is the decision on what to spend the money. We call that resource allocation. And lately, there have been some very important discussions about the role of CBHI in funding some of the guaranteed services that citizens receive through the public system, what are referred to as the exempted services. And should CBHI be funding some of these services, or should these be funded primarily by the government's main channels of funding? So in these questions also land in challenging ways on the regional authorities and also on the Warada level authorities, who are still mobilizing significant resources through payments by citizens themselves to meet the needs of services that are not adequately financed from other sources, or where the financing and the inputs are delayed. And the last thing I want to talk about is the question of payment and purchasing of services. This is a very important topic right now in Ethiopia. You have developed a very strong governmental healthcare delivery system, state-financed healthcare delivery system, in which the funding flows through the standard government funding channels to support the human resources of the system as well as the other inputs. But there's a very active debate about the incentives that this kind of system provides. And I want to emphasize that financing is very much about behavior. It's about the behavior of the actors who deliver healthcare at the ground level, in the sub-centers, in the health centers, health posts, and in the hospitals. Now, there's interest in whether one should introduce more direct incentives to individuals through various kinds of performance, what are called performance-based financing. And this is attractive because it tends to motivate people to deliver certain kinds of high priority services. But the evidence on how well this works is mixed in different countries. And there are a couple of things to be concerned about. One is that this kind of financing involves significant administrative costs. So you not only need to make payments to individuals, you need to track the work that they're doing, because that's what you're paying for. And there's also concern that this could undermine, to some degree, the motivation, the collective motivation of the workers in the system to work together as a team and to work in a very well coordinated way in the facilities where they work. Another way of thinking about these incentives might be providing them at the facility level. So incentivizing the facility as a team to deliver certain services, or potentially even incentivizing the district as a larger team, the Warada, to deliver certain services. And I think these are questions that still need to be answered empirically in the Ethiopian context, because the challenge of maintaining good motivation and teamwork of the human resources, and also the challenge of the high administrative costs of more detailed approaches, really needs to be considered when we think about the efficiency of the overall financing system. So I think I'm going to stop there. I hope I've introduced some thinking about these important questions. Experience around the world is highly varied in these areas, but really the question for you is to find the right solutions that work in Ethiopia, in Oromia. And my view is there's not going to be a one-size-fits-all answer to this question. Really, it's going to need some adaptation to local conditions. And even within Oromia, you have a very large and very diverse region. So perhaps you need to have different approaches working in different places to solve specific problems of utilization and access and quality of care and equity and targeting of those who are most in need of support. Okay, thank you very much, and I look forward to listening to the other presenters.
Thank you, Peter, for the very enlightening presentation, and I hope we've collected a lot of information from that. And the most important thing he raised, and I can also echo on it, is like, even in Oromia, we may need different scheme of healthcare financing. We know there are schemes at national level, at sub-national level, even beyond the regional level, we may apply different financing scheme. And thank you for again reminding us the basics of healthcare financing. And we all know that healthcare financing is only a decade of age in Ethiopia. So far, it has been donor and out-of-pocket dependent healthcare financing system. And I would expect pointers from the participant. So the next speaker will be Sister Opse, again from online. Please, can you allow her to go in?
Can you guys hear me?
Can you hear me, Sister Opse?
Yes, I can.
Great. Great to have you again. And it's your time, Sister Opse, and you can go ahead. So she has some slides to display. Please, can you share her slides?
Thank you, Dr. Yadata and the Oromia Health Bureau for inviting me to this research conference. Though I did not do any research, so I'm just here to share my personal experience with you all. I was introduced earlier by Dr. Yadata. My name is Opse Lugo. I am originally from Oromia. Currently, I'm joining you all virtually. I was given to speak on the role of philanthropy and building healthcare system. Although philanthropy cannot replace an effective and assertive government response, but it can enhance it, especially when the problem's complexity requires multiple stakeholders working toward a common goal. That's why I'm here. My job in Oromia does not replace what Ministry of Health or Oromia Health Bureau or the Oromia government is doing in Oromia, but it is enhancing and it is it's to help it. So next slide. Why am I here with you all today is, can you put on the next slide? Sorry. As Dr. Kabade had mentioned earlier, there was a talk this week about the malaria surge in Oromia and other parts of Ethiopia. My humanitarian work began in 2009 when I first visited the Nejo Hospital in Western Oromia. As you can see, the girl on this picture was 9 years old, came from the remote village of Nejo. I think they walked about 6 hours. When they got to Nejo, they did not have any malaria medication for this girl, so they transferred her to Gimbi Adventist. Gimbi government hospital was not built at the time. I was on my first mission trip there. I didn't know what to do, so I myself and the nurse who was with me gave money to the parents and sent her off in an ambulance to Gimbi. And a couple hours later, the parents and the ambulance returned. This girl passed away on the way to Gimbi. That is how I started. She died. She passed away from cerebral malaria. So the issue of malaria is very near and dear to my heart. That is how the foundation of this medical mission trip in Oromia started. Ever since 2009, I've been traveling to Nejjo and other parts of Oromia to provide basic medical cares. I feel like healthcare is a basic human right for everyone, and mostly for the Oromo people. I could only speak for the Oromo people because that is where my experience lays, and that is where I'm from. So I've traveled to Oromia with cardiologist, ophthalmologist, plastic surgeon to do cleft lip. We've taken cardiologists from Finfinne, Dr. Sambeta, who was on a mission trip to Nejjo. Dr. Mulu Murlata was a fistula surgeon who traveled to Nejjo and did a fistula surgery on women who've been battling with fistula for over 18, 20 years. Next slide, please. And this is Dr. Hussein doing a first echo at Nejjo Hospital back in 2011. Due to this, I took 3 children to India for an open heart surgery, which was not available at the time in Ethiopia. Currently, I hear there is VSD repairs or any type of open heart surgery has been performed in Finfinne, which is a big progress from 11 years ago. These kids were back to their parents and leading a normal life. We've done, like I said, cataracts, cleft lip, visiting IDPs and fistula. Next slide, please. And lastly, again, we see a problem, we act on it. On the next slide, please. So this boy, I'm the girl next to this young boy who is 11 years old, who passed away back in 2013 due to lack of oxygen in Nejjo because they had to travel to Finfinne to refill their cylinders, and they only had enough oxygen for 1 or 2 patients at a time. So this boy passed away from asthma attack due to lack of oxygen. Because of that, we lost this young boy who was full of hope, full of life, but again, not to lose more kids, not to lose more people from a basic and preventable illness like asthma or pneumonia or what have you. So I collaborated with Rotary International to build an oxygen plant in Nejjo, which is serving the entire Western Oromia region and Benishangul Gumuz. Currently, Nagamte has one, so this kind of took the burden off of the Nejjo Hospital. Next slide. And the most recent one is visiting IDPs. I visited IDPs, internally displaced people of the Oromo people from Somali region back in 2017 in Harar, Hamarisa camp in Dredawa. And this year in March, April 2023, I visited Shambu in Western Oromia IDP site, along with a colleague, Dr. Gambachu, and others from Wallagga University. And also we visited Girja, Guji Zone IDP site with Dr. Balaine, who is one of the panelists on today. So all this work that we do is, like I mentioned earlier, not to replace what the Oromia Health Bureau is doing or what the government is doing, but to enhance it. We work together, we're for the people. The role of humanitarian as humanitarian, we cannot function without government support, without the Oromia Health Bureau support. Hand in hand, we could save more lives. Our people are dying due to a simple disease, lack of medication. I know currently in Oromia, due to road closures, be war or natural disasters, most places are not getting the medication and the supplies that they need. We come in to elevate that as much as we can by working together, and by collaborating, we could build a better health system in Oromia for Oromo people. We could only do it together as one. Our cohesiveness, our togetherness would help our people more. And this is the time that we all could collaborate more than ever to tackle the natural disasters and the illnesses, malaria, cholera, even chronic disease that is killing our people day in and day out. Our people are suffering from wars and whatnot, and we cannot afford to lose more lives by malaria and by cholera and other disease. So I'm here today as a supporting entity to the Oromia Health Bureau and to the Ethiopian Ministry of Health and to nurses in Oromia. I'm your cheerleader. I'm here to support. I will stop right here. Thank you so much for having me, and I will stay tuned for any questions. And I'm honored to be on this panel along with Dr. Kabbade and others who are on this, and Dr. Balaine as well.
Okay, thank you so much, Sister Opse. Yeah, probably you will have only a few minutes with us, and if you add some couple of points about these philanthropy activities or any kind of future way forward that you can put in order to support the health system. Yes, health system, as we heard earlier, is a complex and also suffering from limited resource. Kind of way forward. Yep.
Okay. So the way forward would be, like I mentioned, collaboration with Oromia Health Bureau, Ministry of Health, and the Oromia Regional Government to bring in more supplies and more resources to resource lacking areas. We have a lot of remote areas in Oromia that we cannot even get to by car. We have to use donkeys, motorcycles, bicycles, or on the foot. But collaboration is the way forward, making it easily accessible for a lot of us from overseas to bring in supplies, to bring in bringing more experienced physicians to train our doctors who are in the remote area, even in Finfinne and other parts of Oromia. So accessibility and collaboration is the way forward. Like I said, our togetherness and our cohesiveness will help our people more than ever. And this is the time that we could collaborate to help our people and help the health institution in Oromia. I've seen a lot of change. I've been doing this work for the past 14 years, since 2009. I've seen a lot of change. I introduced a wearing of scrubs at Nejo Hospital when none of the hospitals in Ethiopia were not even wearing it except the OR techs and OR scrubbers. But that is where we started. I know most of you have more experience than I do, but my experience started from a remote village, a remote hospital that was working with 5 GPs, serving over 1 million people with the limited resource. But again, this brings us back to the collaboration that I had with the Oromia Health Bureau, the collaboration that I had with regional and local health bureaus to help the people. We are here to help the people, nobody else. I'm not here to help my people. I'm going to call on Dr. Mengistu. Dr. Mengistu or Dr. Boqonnaa are not here to help themselves. They are there sitting on that chair to help their people, so we could collaborate and help our people more than ever. My takeaway message for way forward is accessibility and more collaboration among us. Thank you.
Okay, thank you so much just for your work and also joining us for this panel discussion. And if you have time urgency, as mentioned earlier, you are excused, but if you have time, you can stay with us and hear some comments from the participant as well. The next panelist will be Dr. Balaine. He will have, again, 5 to 6 minutes. And please, may you share his slides?
Fayyaa oltanii? All right, so I don't know if this is the right audience for me to speak to. I am very young and short experience, but there are some younger people in here. So I have a few slides. In my presentation, instead of listing what I have achieved so far, I wanted to share my experience of why I am able to achieve something in an institution that I worked as a professional or as a leadership, and I have worked in a different leadership position for a short period or for some longer period, and relatively, yeah, the first slide. Slide one. Okay, good. Yeah, all right. So normally, why I am successful compared to, I feel I am successful compared to my peers in leadership because I brought some tangible changes onto the system, but I don't want to list what I have achieved. Why do I was successful there? So in my principle, life philosophy is very important. In approaching our responsibilities, our roles as healthcare professionals, our life philosophy is very important. And okay. Sorry. So, I am from farmer family with illiterate father, mother, and the father is not alive. And, well, where did the slides go? So, my life philosophies comes from my childhood life as a son of farmer. And in the first slide, if it is visible, yeah. So if it is visible, asirratti yoo argitanii namichi kuni oodiidhaa jiraa. Oodiidhaa. So oodiidhaa kana keessatti akka argitan qotiyyoo jira, qotiyyoo gurraacha jira, burree jira, namicha jira, ulee inni baate jira. So I draw like 30 principles of life from this. Namichi kuni qotiyyoo kanaan yoo qotu akka argitan jalqaba it requires a team to achieve something. Qotiyyoon tokkichi qotuu waan kana dha'ee ji'atti illee geessuu hin danda'a. Garuu yoo hedduu ta'anii dhaanii yeroo tokkotti, yeroo gabaabatti, guyyaa tokkotti fixuu danda'a waan ta'eef it requires a team to achieve something. So I believe in teamwork. Teamwork is very, very important. And the second thing, warri baadiyyaatti dhalatan akkuma beektanii namichi tokkichi qotiyyoo ooyiruu tokko guutuu dha'u kan qabu nama xiqqoodha, humna kan qabu. Ollaarraa, qotee bulaa biraarraa walitti yaasetu walitti ergisanii dha'u. Collaboration is very important. I believe in collaboration. Akka argitan kanatti directionii tokko deema. They work in the same direction. Andu odohala, andu odafit bihed, aisakam. So they are doing the same task, doing the same goal, and they are working to the same direction. So as a team, I said team is important, collaboration is important, and togetherness, working in the same direction as a team is very important to achieve something. So in this picture, usually they say, namichi kuni qotiyyoo kana yoo oofu, nanaanna'ii jorroo koo, nanaanna'ii gurraa koo, nanaanna'ii burree koo, nanaanna'ii dafiitii, akkuma addeessaa, akkuma aduutti, odoon roobni hin dhufin, odoon dhiinnutti, callaan kan koo ta'us, galabaan kan keetii jedhaan. So, amma namichi kuni qotiyyoo isaatiitti itti haasa'aa jira miti. Tiimii isaatiitti itti haasa'aa jira. Communication is important. I believe in communication. Communication kana keessatti baay'ee jira. Gurraa jira, jorroo jira, booqaa jira, hunda isaanii maqaadha. So in the team, in healthcare, I am a doctor, a physician, but I need every professionals and the supportive staff to achieve my goal. ሁሉንም ነው ወደፊት እንሂድ በርታ ሩጥ ተነስ ማለት ያለብኝ ማለት ነው። Secondly, dafee jira. Time is important. Nanaanna idafii akkuma addeessaa akkuma aduutti odoo roobni hin dhufin odoo dhufiin nutteedha namichi kun. Yeroon baay'ee barbaachisaadha. So timeliness is very important. I believe in time and in time management in my administrative principle. Second, good examples are very important. Learning from others. Addeessi aduun robulle duumessaulle bakka ba'anii sanitti haga lixanitti hin dhaabbatan. Irrespective of the obstacle, irrespective of the environmental situation, መድረስ ያለበት ቦታ ደርሶ ያድራል ጧትም ተመልሶ ከዛ ይወጣል። And finally maal jedhe namichi kuni naanna idafiti callaan kan koo ta'us galabaan horii biqiin kan keeti. Life is a transaction. Maybe in work it could be reward and recognition, you can take it as it is, or if you do something good you gain something. Therefore reward and recognition is important. As a leader in my institution, if I can't give benefit, if I can't increase the salary of my staff or their duty rate because of the system, I can give reward and recognition. So I draw this principle from this picture. And finally, I tanir taniyota e nakisuni ule qaba. Oduma farsu, oduma fiigi jedhu kan duubatti jedhe qaagod. So I believe in accountability. Accountability is right? Accountability is the most important part of our daily routine. Somebody should be accountable for not doing what he is expected to do. Gama biraatiin hodhaanii gitanii hojjettani in nyaatu miti. In nyaatu gadi jedhe. Oo gadi jedhe nyaate maal godhan? Afaanidhaan. Hoo duubatti jedhes in dhaama. Hoo nyaate afaan isaatti dhamaa jechaadha. Some form of punishment is involved. በኋላ ግን ገለባ እንተ ነው እየተባለ ውጤቱ መጨረሻ ላይ ይደርሳል እየተባለ በመሃል አጉል ነገሩ ከገባ ይቀጣል ማለት ነው። So I believe in accountability. So most people don't like this part of my management. You know, they don't like it because in our culture, if you punish somebody, you're considered as a very bad leader, you know, but you have to reward and you have to punish. Balance is needed. ዓለም እስከ ኒውክለር ቦምብ ድሮን ሄደው አንበሳን ወይም ሰይጣንን ለመምታት ሳይሆን የሰው ልጅ አስቸጋሪ ባህሪ ለመቆጣጠር። ስለዚህ punishment is part of life. And the second one, I follow this principle. This William Edward said, he is a physician and he works on quality. He said, in God we trust. All others must bring data. So I really don't believe in oral reporting. Akana godhen ture, akana godhe jira, akana xaaren jira, akas godhen jira, akkasitti. So I believe in auditing. If you have seen in hospitals, there is a clinical audit manual that they are using, and I wrote that manual initially. So people excluded my name from it. Later on, and they owned it. I wrote that manual completely with my team at Shashamani Hospital. We do auditing, absolute auditing for everything. If we go to obstetrics ward, we audit how many deliveries that midwife has attended, his documentation, whatever needed in detail at individual level, and also resource auditing, which has increased efficiencies in health institution. So my relationship with my staff and other management members depends on evidence. So I believe in data, and I believe it should not be optional not to record a complete data. ስለዚህ ዳታ ሪከርዲንግ አንድ ባለሙያ መመዝገብ ያለበትን ነገር ሳይመዘግብ ከቀረ አይቻልም ማለት ነው። ቅድም የነበረው ዱላ ይመጣል ማለት ነው። because it is not optional, it is part of the responsibility. So these principles, in addition to the professional responsibility I acquired as a doctor, will help me to improve for the future, and also my theme. And one more, yeah. So if you see here in a different literature, the dimension of quality is listed, and you can see most of them are very simple, and it requires only behavioral change in most of the circumstances. Patient safety at risk ላለማድረግ ለምሳሌ simple እጅ መታጠብና አልኮል መጠቀም ብዙ ነገር ያድናል አይደለ? በሳይንስ ስንቶቻችንን እንደዚህ የምናረገው በሆስፒታል ውስጥ ይሄ አዲሽናል ሪሶርስ ወይም ፎቅ አይጠይቅም። Effectiveness, matching science versus care. Nowadays, in most of our healthcare system, it seems as if there is a declaration of universal coverage of antibiotics. Anybody who visits health facility will go out with some form of medication, particularly in private practice. So this is not an effective system, and this only requires, you know, change in mentality. Patient-centered care, we are way back in this. No, in our system we follow paternalism. Patient to minnosnillet እኛነን ግን የኛ ሮል ፔሸንቱን አብቅተን ስለ ጤናው እሱ እንዲወስን ማስቻል ነው። እዚህ ላይ በጣም ብዙ ስራ ስለሚቀር መናገር አልፈልግም። የጊዜ ጉዳይ ታይምስ ዮ ተጃጅለምቶታ አርጊተኒ ጀትኒ ማሎ ናን ኦልቺን ናን ቡልቺን ከራንዴማ ኮኮላታን አርገዱ ጀዱ መሌ በኪቲነ ያልተ ኩን በሬዳ ምትን ጀደን what is our culture? and opd ሚገባ ሐኪም ወልቲ ቀቢና ኤግ ወጋ ፉርሸን ታን ናሚ ናብል ብል ጀደ ደማ ማለ ታኤ ቶኮ ቶኮን ካን ዱፌ namni yaalu baay'ee miti. Rizaaltiin illee walitti qabiin yoo hundi isaanii rizaaltiin dhufe na bilbili jedhee deema. Sun we are not time sensitive, and that will prolong the patient's waiting time or stay in hospital. Again, appointments. እነዚህ simple culture shift በማድረግ የሚቀየሩ ነገሮች ናቸው። Efficiency. So the first time I visited Shashamane Hospital to see how the hospital is working, I go to wards and I go to staff toilet, and the toilet basket is full of surgical gauze, and I go to another one, it is full of surgical gauze and it is being used as a tissue paper. And the same day, accidentally, I found out that patient is being referred to Awasa because there is no surgical gauze. You know, so the way we look at the resources we have is so deficient, you know. So hospitals can maximize the use of resource, and our professionals should know that every single syringe matters. And in terms of equity, obviously, I didn't see health professional discriminating patients because of race, sex, or gender. There will be a challenge because of geographic variation. But what should be our role? Our role is to go to the remote areas. Now, if we have compared the number of physicians here in Finfinne to those in periphery, you know it. Dr. Mengistu cannot improve the access to caregiver unless we take a responsibility to go to Moyale, to go to Begi, to go to somewhere else. So we have to play our part. ማንም ገጠር ሂድ ሲባል አሁን ይሻልም ማል ካልተመደብ አዳማ ካልተመደብ እንደዚህ. So but there should be a system. I understand somebody who decide to go to Moyale should not stay there for 4 years. There should be a responsibility or a form of rotation to send health professionals to the remote and the difficult areas. If it is our turn, we have to decide to go there. And my last slide, so these principles are simple if we are serious enough about that. And the other most important thing is health literacy. ይሄ ደግሞ አሁን ቅድም እንዳልኩት እንደ ፔሸንት ሴንተርዱ ብዙ ማንሰራበት ነገር ነው። አንድ ጓደኛ የሆነ ጊዜ ምን አለኝ፣ ከለቱ በፊት ነው አደራችሁ እና ቴሌቪዥን እያየን ኢትዮጵያ በ10 ወር በ15 ዓመት ውስጥ መካከለኛ ገቢ ላይ ትደርሳለች የሚል ዜና ስንሰማ ጓደኛዬ ምን አለ፣ ወዳጄ ይሄ ህዝብ መካከለኛ ገቢ ከመድረሱ በፊት እንድረስበታል። ምንድነው አልኩት። ይሄ ህዝብ እኮ ጎመን መብላት፣ ሽሮ መብላት፣ ድንች፣ ቲማቲም መብላት ድህነት አስገድዶኝ ነው ብሎ የሚያስብ ቢቻለው ሁሌ ጠጅ የሚጠጣ ቢቻለው ሁሌ ጮማ የሚበላ ህዝብ ነው። በአስተሳሰብ ደረጃ መካከለኛ ገቢ ደርሶ ያንን መብላት ከጀመረ ክሮኒክ ኢልነስ አገሪቷን ይወራታል። ስለዚህ አሁኑኑ ከዚህ ድህነት ሳይወጣ በፊት ይሄ የምትበላው ሽሮ ጥሩ ነው ብለን ማሳመን አለብን። ምክንያቱም አለኝ እኛ ሀገር እንዴ አንተ ይሄን ውሃ አፍላና ጠጣ ህዝብ ይጠየፋል። እዛ ጋር እኮ ሽንት ቤት ሰው ሜዳ ላይ ተቀመጠው እየገባበት ነው ሲል የሚጠየፈውን ነገር ያልተወ ማስተው ያልቻል ነው። ማመንዘር ክፉ ነው እያለ የሚያማርር ማህበረሰብ ግን ኤችአይቪ የተስፋፋበት ጮማ መብላት ጥሩ ነው ብሎ የሚያስበውን ማስተው ምን ያህል አስቸጋሪ እንደሆነ ማወቅ አለብን። ስለዚህ እንድረስበት ነው። ሶ ሄልዝ ሊትረሲ ላይ እኛ ሆስፒታል ገብቶ የወጣ ሰው ህመሙን አያውቅም በብዙ ጊዜ እና በዛ የተነሳ እናስተምር ነው። we have to advocate, we have to educate, and if unless we educate our community we are not going to go far. Thank you.
Slide, please. Yes, ma'am. Okay. Yeah. Okay. So here is gender and healthcare leadership. So as you know, the women continue to be underrepresented in top levels. Especially, we can take this conference as example. I can say the most of the women responsible people participate in the conference is almost 99% is male. So this is under representation of women in this high-level conference and other status. So here is a recent report shows that the women hold around 70% of health worker job globally, and over 80% as a nurse, and over 90% is midwife, and also delivers a major unpaid care and domestic work in the family and the community. And the woman also held the delivery of health, delivers health to 5 million people, and continue contribute at estimate $3 trillion annually. And also women only hold 25%. As you see the figure, 70% of the women is involved in health work environment, but the leaders is only 25%. So when you see the men are less than 30% contribution in health force, but about 75% of leaders in her system is male. So this shows that how the woman is underrepresented in top level management. So the figure also, recent figures also show that, as you see, only 25% of women involved in hostile CEOs. So here is a great problem in our country and as a globe. So please, next. So this also represented for women by seniority. So if the leader rules was allocated proportionally, assume that the woman and the men have equal merit. So then, since the women are 70% of health workers, 70% of health sector leaders will be the women. But in our context, it's the reverse is true. So the figures also show that about 25% of the women are involved in a leadership position. So here is most of the time in the global, in our country, most of the stakeholders talks about women gender equality, but the ground, it's still the problem, not only in developed country. In developed country also, this is a great problem. So every stakeholders, professionals, and the government must be focused in this area to increase women leadership in health system and other industries. So here is a woman's benefit of women to be a leader in health system and other industries. So the institution study indicates that in institutions that the women involved in leadership position, the subordinate and the other workers have more satisfaction as compared to the institutions that lead by the men, and decrease burnout of the subordinate and the workers, and also there are meaningful work in the women that lead the institution, and also the women are more organizational dedicated, so they are motivated to lead and they have used their motivation, and also the women also use the resource in effective and efficient way, and they are capable to also resolve the conflict between the workers and the other management. So it is very important behavior of the woman or capacity. So in recent years, the companies have hired more women for top executive position, while the gender gap is still quite larger. Organizations now realize that the value of women leaders and the benefit for more diversity. According to the statistics, over past 14 years, the women in workforce have contributed to more than 20% of overall GDP. So this is not a little number. So women have a great involvement in this aspect. So here is the women's unique leadership characteristics. The women leaders are more pursued than the males as compared to the males leadership. And when feeling to stealing of rejection, the women leaders learn from advertising and also carry on with I will show. So by this attitude, they can achieve the outcome, achieve the goal of institution. And the women leaders demonstrate an inclusive team building leadership styles and problem solving and decision making. So by team leading and also problem solving capacity, the woman can achieve the goal of the institution. So the women leaders also more likely to ignore the rules and take the risk to achieve the health care system outcome or achievement. So this is the most important characteristics of the woman to be as a leader. So here is a challenge. So there is different challenge in the different dimension that inhabits the woman to be a good leader. So as organizational, so in organization, most of the organizational system is not good, not favorable to be the woman to be as a leader. Some there is no equal, low hiring and promotion capacity for the woman in institution, in health institution and other industries. And when it's also a empowerment challenge, women most of the time not empowered from the family. It starts from the family to also the school and the institution. The empowerment capacity of the other people is very low because as a woman may have no interest to be a leadership in health sectors. And the personal challenges here also. The women have no desire to be a leader in an institution because of, I can say, low confidence, and because these people have no support from the community, from the family, and the other stakeholders. So because of that, they have fear of being this leadership position. Because of that, it's very difficult to be a leader in different institutions. And the cultural challenge, the most common problem is gender stereotypes. So the community and the family, other stakeholders give some rule for the females. So most of the time, the community thinks that the leadership position is for male. So the female is normally, the woman is occupied by other home activity and caring the children. So this is the community challenge that faced the woman to be, not to be the leaders. So here is the point. And so how would be the future for global health change with more women leaders? So first one, the women have a right to be equal decision-making roles. So we ourselves, we have to decide the men and the other stakeholders must be believe that the women have the right to equal decision rules, and we have to provide access to opportunity for growth and development. So most of the women have no skill, leadership skill, because they are frustrated to be a leader in different organizations. And enable the women access health leadership equality. So on different institutions and including health system, the higher official men management or leadership has no confidence in the woman to be a leader. So we have to give a chance to the woman to be a leadership equally with the men. So and in discrimination against the working as a mother. The most important point here is that in men's management and the government also thinks that the woman have some obstacle during pregnancy and during delivery she may miss her work. So there is maybe the gap maybe happen during this period. So because of that, the men or others stakeholders feel to be give promotion for the women and provide equal pay and foster exclusive mentorship very important. So we have to encourage the mother and mentorship the mother to be a leader. So here is the opportunity because I can pass this one. Okay, I think I finished. So here is a message for women to be a leader. So thank you. This is my part.
Thank you very much, Dr. Maleda, for just bringing in some of the challenges we have at different level to bring women on leadership and how the critical mass looks at lower level and then how it depreciates when it goes up. And by virtue of your current position as the president of Ethiopian Nursing Association, I'm sure this word would inspire or give insight to our young women to come on board. And thank you for that. So saying this, we'll move on to the last speaker, but not the least, Dr. Godana. He will talk on building public-private partnership to meet the highest public health needs.
Okay. Thank you for the chance, dear moderator. My name is Godana from Adam Hospital Medical College. Honorable Dr. Kabada Warko, our elder brother, respected senior professional, Honorable Dr. Mangistu Bakala, a good friend and head of Oromia Regional Health Bureau, Honorable guests, scientists, and all participants to this conference. I'm really happy and honored to be selected to participate and also to be the panelist of this conference, because for one thing, it is homecoming for me to see Oromia Health Bureau, where I worked many years back as head of HIV programs during Millennium AIDS campaign, where I happen to know many of my good friends like Dr. Kabade and others. Second, I know the challenges many years back of just organizing simple review meeting and annual report of Bureau has evolved over years to a standard scientific and international conference of this level. So it is a great achievement, and I want to congratulate the leaders of Oromia Health Bureau. Thank you very much. Beekena maal jedhani namni gaafa jaarsatti dhufe ebboo ati maalii jedhe biiroo dhufennaan hin beeka nama kana maqaanis hin beeka hojii isaas hin beeka ati maali jennaan ani durtaa'aadhaa jedhe durtaa'aa biiroo kanaati jennaan dhugumaa jedhe hagi si argine nuti teette malee hin deemtu kanaaf wanni dhufneef nu dur deemi yookaan nu duraa deemi jechuu dhufnee jedhe. So biiroon baay'ee deemaa jira. I thank you that. And lammaffaa immoo dubbiin mammaaksaan dhumti jedhanii jaarsum kanatti gaafate ayyee durtaa'aadhaati maal hojjette biiroo kana jennaan aan itti gaafatamaa miti maal hojjette akkam jennaan eentu takkisi gaafate beekaa waan feetes yoo gootee jedhan. So, you know, hojiin geggeessummaan itti gaafatamummaa guddoodha. The reason why I say it is the patience, the way this conference is organized, to be able to listen to everybody, expertise of everybody for the input of, you know, moving this bureau and this big region and the country at large forward is a big decision and a big, you know, thing to do. I actually am not just a panelist today. I was really a good student because I learned a lot from what people said. What people said here, it is like, you know, lifetime experience. Having said this, before I, you know, go to my topic of talk, which is public-private partnership, I just want to forward a few questions to you. God forbid, what would you do if you just fall sick right now? Where do you want to go to? Because things should be practical. Wada mangist hospital no, wada gil hospital no. The other is, where do you think majority of people of this country go to when they just fall sick or ill, like I asked you? And the most important question following these two is, what are the criteria or points that help you in deciding where to go? What are those things? And I'm sure some of the answer might be, I go to private hospital, I go to government hospital. Some people say, I start with government and go to private. Some others say, I try with the private and then shift to government, or vice versa. Some would say, one leg in private, the other leg in government, so that I get the best out of both. So, the reason why I said this is, maybe there is no perfect answer for this. The answer is, we should maximize utilization of both, which leads to the topic of today, a partnership between the two institutions, government and private. I didn't want to say public-private because private is also public. It's service public. So it's a kind of, long-term contract between the two for the same goal, because everybody wants to have what? Cure from the problem and seeing, healthy society. The only difference is one is funded by government, the other is funded by private. And above all, government is responsible to make sure that everything is spent in the right direction for the general health of the population. So, while, making this partnership is not for free. You agree for long term on what to do, share your responsibilities, and also take risks, decide to share the risks, not only the benefits. And that should be what partnership is. And this is quite known in, areas of finance, partnership. But in health, it is quite recent that government and other, not only in Ethiopia, but in the world, people have started to, see partnership is very important in moving forward and achieving healthy, society. This is usually based on understanding of existing structure, both in government and, private, experiences in both sides, and practices. So whenever you probably decide where to go, it depends on what are the structures, what are the experiences and practices in health facility that I would be going to. And this has something to do with access. Number one issue is, which one is the nearest to me? Which one can I access easily? The second is quality. Which one gives me better quality? And where do I feel safe, actually? Quality is related to safety. Where do I feel safe? And the other is it affordable? The next question is, you don't just run into somebody's clinic without money. So, is it affordable? And the next is, more important, where can I get sound, compassionate, and respectful care? So this is what you calculate, I'm sure. I don't know. And these things are not at a spot. They have to be there sustainably for everybody and equitably. This has been, talked about in the healthcare insurance, healthcare financing. So equity and sustainability is also one of the issues in, considering partnership between, government and public. So I feel like private and government partnership is not a choice, but it is a must. You cannot choose to walk or try to walk on one leg, or you cannot neglect my, left leg is more important than the right. So you need both of them. And they should be paired, coordinated, in a coordinated manner, harmonized one. But the next question is, what are the areas and priorities of collaboration or partnership? And what are these areas? Can we partner in terms of clinical care, supplies, programs, and also at the level of primary care? I think the world and Ethiopia as well has a lot of experience of this partnership. Like, for example, simply in primary care, we have seen with many programs like HIV family planning, where a lot of social marketing approaches have been adopted in HIV prevention, in family planning. This is partnership. The other is outsourcing, be it clinical or non-clinical services, like, catering, security, and now, for me, it needs to expand to, other services. Because you cannot achieve, expanding health facilities as a government of poor nation. You cannot build hospital for every warrior that asks to have that. You cannot buy machine for every warrior. We have seen that. Even if you do, you cannot sustain doing, and running it. The healthcare issue has been, health financing issue has been raised. And I have, experiences at least, as someone who grew up in this system, from being a general practitioner assigned to a very remote hospital, Nagel Borana, some 17 years back, as the only doctor. Dr. Mangistu, a good friend, knows he was also suffering on the other side of, the region, assigned somewhere. And I tell you, in healthcare, I don't tell you detail what I faced there. I was medical director. There was no CEO system. You can guess how old I am when I tell you this. So there is no CEO system. You are medical director, you sign on everything. On top of that, I was called by Biiroo to train for emergency surgery and obstetrics in Adama, and I delegated the only available senior nurse as a medical director. So I spent some 3 months in Adama, completed those training, and went back and did many C-sections and laparotomies before I decided it is enough, and I joined internal medicine actually because I have done my part. So the challenge, as a young doctor you face, is immense. And we used to blame everything on government. We used to ask people, why don't pay this? Why don't you bring that? Why don't bring this? But now, after, staying in Oromia Health Bureau, leading some programs, particularly during Millennium AIDS campaign, the issue of partnership has been more clearer than any time for me, that partnership is important. And the third important event that made me believe partnership is indispensable is COVID-19 epidemic, where Oromia Health Bureau actually pooled a lot of personalities, expertise, and resources, saved the region, and also was an example for the country too. So partnership between private and public is indispensable part of, healthcare system. So I just wanted to say finally, if we think of government and private as a separate entity and sometimes as a rivalry, then we are in the wrong thinking. So it is time to think differently and work and invest on private and public partnership, because for a change to come, as one of a change scientist said, insanity is doing things the same way again and again and expecting different results, by Alexander Deming. And we should now think differently and work together as a partners. And finally, I would like to say partnership between government and public hospitals and healthcare system in general is indispensable toward this shared goal to achieve, healthy, community, but also taking all the responsibility and risks that come, in the way. Kanafu, hundi keenya ilaalcha yeroodhaan namni martinuu kan barbaadu fayyaa uummata kana jijjiiramee arguu waan ta'eef, the thinking should change that to the level of the first question I asked you, where do you want to go? We should work toward this. It doesn't matter wherever I go, because I would get standard care in terms of access, in terms of quality, and in terms of equity and, affordability. I cannot go into detail of those things. Thank you very much for having me.
Thank you very much, Dr. Godana, for just sharing us your ample lived experience, and he tried to touch how he coped up with serving in remote areas, and also told us his experience when he served in different positions. And the final point he made, we have to think differently. Business as usual wouldn't work in the high needy health system. So thank you for bringing that concept in your talk. So saying this, I would directly move on to comments or questions, and I will allow only one. So if you have any comment or question. Okay, is there 1, 2, 3? Okay, great. So 3 people. Number 1, there.
This is Qo'annoo Marsaa from Dila University, and I'm very grateful for all panelists. They shared us unforgettable stories which are motivational as well. My question goes to Dr. Balaina Lata. I'm very impressed with the metaphor you told us, and also with all the stories you told us. And my question is, where shall we found your organization and also the professional association you are leading, and maybe also personally after some 5 or 10 years, where shall we find you? And because that, at this age you achieved a lot of things, both in the organization as well as personally. That's why I am asking. And the next question is, any of the panelists may react on this question, and that is maybe a good example from my institution, Ethiopian Nutrition Leaders Network. Maybe this may treat lots of problems that panelists were raising, like Dr. Balaina also raised about the abuse in the infrastructure, and also the resource wastage from health professionals, and abuses are also there. So if we work on the personal development and leadership of each healthcare provider, I think we can erase that. So the good example is we give decision-making, time management.
Can you shorten your point?
Okay.
Yeah.
So if we are capable of making every healthcare provider a good leader, I think whether Dr. Kabada is available or not, everyone can do to their level best. So how is your appetite to incorporate soft skill trainings to all healthcare providers to make them competent leaders so that they can lead also upward? Thank you so much.
Number 2.
Okay, thank you very much, all the panelists. Then maybe I want to just ask Dr. Kabade, because he told us a lot of acceleration programs during his leadership positions, and how do you see now those acceleration programs now? We are hearing very recently a move from the health system about task shifting now. Maybe in most cases, the low-level health professionals are actually repurposed for the sake of clinical care rather than actually the community health practice that was meant for acceleration during the early era. So if you may comment about that observation. Related to the healthcare financing again and the public-private partnership, obviously, yes, there are limited resources from the public. The public has to prioritize the limited resources for those who are most in need. But the private sector usually, or the private is usually profit-making now, mostly. But if we do reality healthcare, if you just make the healthcare, actually, is healthcare actually profit-making? That is what maybe the private sector didn't actually mention explicitly, because we observe nowadays from our private healthcare providers a lot of profit making rather than actually providing the ethical care that we already committed to. So how do you comment that aspect? Because when we see all those, that is what I have for the limited time.
Yep.
Thank you.
Number 3. Okay. Did you raise? Oh, it's here. 3 is here. Yeah, here. Yeah, number 3.
Thank you all for the interesting sessions we had so far. Ulfaadha jechuun barbaada. Dr. Kabbadaffaan really is a living legend that we need to stand on their shoulders to learn much from them. Kanaan dura sistema fayyaa keessatti ogeessi olaanan itti hirmaachaa turre. Dr. Kabbadaa barataa ta'een beekaa sirriitti sistema fayyaa biyya keenyaa keessatti iddoo guddaa nama qabanii. Nutis immoo sistema kana keessatti han guddanne gaafiin kiyya maaliidha. Ownership and accountability fiduu fi ogeessonni keenya olaanan sistema kana keessatti bifa kamiin hirmaachuu danda'u. Muuxannoo keessanirraa maal nuun jettu kan jedhu. Lammata immoo partnershipii mootummaa fi abbaa qabeenyaa like private and public partnershipii kana jabeessuudhaa fi interestii mana dhuunfaa jiru kana akkamiin humna hawaasa keenyaa wajjin wal simsiisuu dandeenya. Dr. Godaanaa fi ulfaadha.
Thank you. For the sake of time, I have to stop here, and then let's hear reflections. Sorry for not giving the chance. Yes, cordially. So let me give Dr. Kabde the chance.
Galatoma. Ani afaan ittiin dubbatan kun afaanuma Ingilizii qofa na fakkaate. Afaan Amaaraatis, afaan Oromootis akka dubbatu dandeenyu naa galeera. Afaan Oromoo afaan hojii naannoo Oromiyaati. Akkasumas immoo godina addaa Oromoo naannoo Amaaraa keessa jiru. Suma Jijjiga Diredawaa fi Harariiti. Kakaanii akka ta'u immoo hinuu hawwina. Ka paartii akka ta'e dhaga'een jira garuu ka biyyaa jechuu kiyya. Dr. Balaayifis, Dr. Mallada, Dr. Godaanaa, akkasumas immoo Sister Obsee fi Professor Peter Rice baay'een baradhe. Baay'een gammadees haala isaan itti dhiyeessan. Keessumattuu Dr. Balaayinan annaqaaqee jedhan san waan akkasiis yeroo hundumaa kan argu irraa hin baradha yeroo hundumaa waan sinirraa isan barachaa jira. Gaafiin duratti ka'e soft skill training kan jedhu sistemni keenya wanni nun barsiisu maal maqaasaa ogummaa barsiisaa malee akkamitti seektara kana keessatti hoogganaa godhuu dandeenya hoogganaa uumuu dandeenya jennu kana hin qabu. Inumaayyuu hooggansuma wanni saniitu hooggansuma ogummaa saniitu iyyuu hawaasaan barataa deema. University irraa gaafa bahu dheedhiidha jechuudha. Theoretical understanding hin qabaata. Garuu immoo akkamitti hojiirra oolchaa jedhu san hin qabu. Kanaaf walirraa barachaa deemuun duratti waan kan qotileen yeroo midhaan dhooftu ogdiratti midhaan dhooftu san qofa odoo hin ta'in ogeessi fayyaatis walirraa barataa waliin hojjeta. Waliin hojjechuun humna ta'a jechaadha. Humna walii kennu, walii qoodu, wal deeggaruu. Sanirra taree immoo hospitaalli Adaamaa, hospitaala Finfinnee wajjin sin hojjeta jechaadha. Yookaan Xuqur Ambassaa ta'uu danda'a. Hospitaala maachi jiru keessa waliin ta'uu dhuunfaa waliin ta'uu danda'a. Ogeessoonnis dhaabbataan walitti dhufeenyaan wal barsiisaa deemuun jira. Kanaaf leadership skillii wannoo ta'uusaa murteessaa ta'uusaa hubachuudhaan Ministeerri Fayyaa health sector transformation plan waan irratti leadership incubation program jennee baasnee haala saniin ilaa ammaa namni leenji'aa jira jechaadha. Leenjii addaa, leenjii hooggansa fayyaa keessumattuu dhaabbilee fayyaa yoo hospital management initiative jalqabne sanitti yuunivarsiitii Jimmaa wajjin ta'uudhaan sunis introduce ta'ee jira jechaadha. hoggansa hammayyaa dhaabbilee fayyaa hospitaala irraa jalqabnee dhaawwataan gadi buusuun danda'ama garuu hospitaalonni keenya hojii fakkeenyummaa qabaatan hoggansa fakkeenyummaa qabu yoo qabaatan moodel leaders yoo qabaatan haala soon dhaawataan dhaabbileen fayyaa buufataaleen fayyaa keenyas wanno ta'uu jechaadha. Kanaaf leadership incubation period naannoleen yeroo public health institute yeroo hundeessan isaan kunis kana akka tajaajilaniif waan ta'eef kana ilaaluun gaariidha. Kan obboleessi kiyya kaase task shifting. I have never used task shifting when I was a state minister. I rather used task sharing. There was no task that we devoid from a physician to health officers, neither from health officers to health extension workers. Rather, we crafted the scope of practice for respective professions so that we access services. Imagine when I joined the ministry, number of people living with the virus on ART were only 12,000. And the number of hospitals that were providing were also few. Then we decentralized services to the health centers and to the remaining hospitals. By doing so, we assured access to care, access to services. So we didn't devoid the professional mandate of a doctor, but rather we built skills and knowledge to the nurses and the health officers. The question of it ended, kan wanja kan obboleessi accountability and ownership jedhamu kan keessa dhufa dhaawataman dhufa waan addaa eeguudhaan odoon ta'in ogeessi fayyaa keessumattuu immoo hoggansi fayyaa sadarkaan jiru maalan argadha akka dhuunfatitti odoon ta'in ummata akkamittan ummata kiyyaaf oola jedhee ilaalu qaba jechaadha. Sana hoogde ummannis ogeessonni fayyaatis walumaa galatti sirnichi isa deeggara abbummaan haala saniin dhufaa deemee jechaadha. Kanumaan jira galatooma.
Turbanaayilee 4 minutes.
Okay, thank you. I don't know which question I have to directly answer. So the Oromia Physician Association establishment is in 2080. Dr. Fikadu is here, the Vice President, and as I established, I joined on the day of inauguration, and I didn't work hard for its establishment, but now we're working hard to make Oromia Physician Association the best community service providing association in Africa in the next 5 years. We are already the best in Ethiopia. Don't worry, nobody is recognizing. The Oromia Health Bureau did. The nationals will recognize soon, but we are doing an amazing job. Where do I see myself in 10 years? Now a bit matured, calm, and keep serving. That is all.
Thank you. Good.
Okay, thank you for the questions. The public, private area, public service, the most needy, private is like for kind of affluent people. I think, public and private እንትን እይታችን ሁለቱንም እየቀረብን ስናይ ብዙ ነገሮችን እናያለን። ምክንያቱም ፓብሊክ መገልገል ማለት ፓብሊክ ግቢ ረግጦ ጧት ካርድ ማውጣት አይደለም። ፓብሊክ ካርድ አውጥተህ ሁሉን ነገር ደጅ አሰርተህ ተመልሰህ የምትመጣ ከሆነ ፓብሊክ ተገለገልክ አይባልም አይደለም? And it is not, I tell you, it is not cheaper በዚህ አይነት አካሄድ ማለት ነው። ስለዚህ the issue is wide gap ነው ያለው። Wide gap in terms of access, quality, all. ይሄንን ጋፕ ማጥበብ መቻል አለብን ነው። ይሄንን ጋፕ እንዴት ነው የምናጠበው? እኔ from energetic general practitioner went to remote and then program and then አሁን healthcare ላይም የተወሰነ private ላይም ኢንቨስት እንዳደረገ ሰው የሚሰማኝ the public ህዝቡ የሚፈልገው safest, accessible, equitable service ነው። ይሄንን ማድረግ የምንችለው the first thing is the government cannot say I can do everything. እንደማይችል አይተናል። አለመቻል ብቻ ሳይሆን የተጀመሩ ነገሮችን ማስከር ቻሌንጅ ስለሚሆን health care, by the way, health care expenditure national GDP is like less than 5%. በዚህ ማዳረስ አይቻልም። ስለዚህ የዚህን ህዝብ ጤና ለመጠበቅ ፕራይቬቶች ፎቅ መኖሪያ ቤት ከሚሰሩ ሆስፒታል ቢሰሩ፣ ምክንያቱም ከፎቅ መኖሪያው እኮ ተንደርድሮ የሚሄድበት መታከሚያ ቦታ የለም አይደል? ስታመም ለሊት ለምሳሌ የት ጋር ነው ኤምአይቢ ይዞ የት ነው የሚሄደው? ስለዚህ ፕራይቬትም እንደዚህ ደህና ፕራይቬት ኖሮ ሳይሆን ማምለጫ ነው። በቃ ላትሞት ወይም ሳምዌር ትገባል እንጂ ፕራይቬት ኳሊቲ ያላቸው ማለት አይደለም። ግን ወደ ኳሊቲ መስራት አለባቸው ነው። The issue of profit making, yes, the profit making definitely, that's why they are established for, but profit ህግ አለው እኮ ፕሮፊት ማግኘት ራሱ ህግ አለው። አይ ቲንክ ኢኮኖሚስት ብዙ ሰው አለ። ፕሮፊት ዝም ብለህ የተገኘውን እያፈስክ የምትወስደው ነገር አይደለም። ውሸት፣ ማጭበርበር ማአት አለ። ምክንያቱም እንሰማለን እኮ የአደባባይ ውስጥ እንኳን የጤና ባለሙያ ሆነን ማንም ሰው ይሰማል እኮ ጉበት ነጣ፣ ሳምባ ጠቆረ ተብያለሁ እባክህ ልሞት ነው እስቲ አድነኝ ብሎ የሚመጣለ እና ምንድነው የተጠየቀው? 10,000 ብር ነው እና 10,000 ብር ስትከፍል ሳምባው ከመጥቆር ወደ ነጭ ነው የሚቀየረው። አሜን። ዲሳር ፕሮፌሽናል የሆነ ሰው ይረዳል ይሄን ነገር። ላይፖማ ወጥቶበት ልትሞት ነው ይባልበት ጊዜ አለ። ሁሉም ሰው አይደለም የሚለው ግን ይምላል። ምክንያቱም it is the most በራስ ጀጅመንት የምታረገው ከባድ ሪስፖንሲቢሊቲ ያለው ሙያ ስለሆነ ኤቲካሊ ብዙ ነገር አለ፣ ፕራይቬትም ፐብሊክም። የኔ ቪዥን መንግስት ይሄንን ግን መንግስቱ ስለሆንክ በጣም ኢኖሰንትና ኤቲካል ሰው ነው ማለት አይደለም። ይሄንን እንደዚህ አይነት ጀጅመንት እንዳይኖር እኔው ራሴ እዚህ ቅዱስ ሆኜ እዛ ሰይጣን የሚሆንበት ምንም ምክንያት የለም። If you serve people, then you have to be the same. Yeah, no? The other issue of balancing affordability, ይሄንን መቆጣጠር ነው። Government should be able to, though it is free market ሲባልም እኮ በህግ ነው። In the framework of law ነው ፍሪደሙ የሚኖረው እንጂ ዝም ብለ የተገኘውን የምትወስድ ስላልሆነ I wish government would be genuinely able to control, not only controlling by the way, የሌለ ነገር ኮንትሮል አታረግም. For me, I want to see all the big investors, people with money, to invest their money into, providing a lot of, health institutions and then, investing in that so that the country, the population would have opportunity to get better quality from what they have invested in. And that should be regulated by the country's law in terms of affordability, accessibility, and ethics as well. Thank you.
Thank you so much. I think we only received these questions. Those online, Peter, do you have anything to say? Any final word before leaving? Dr. Opse and Sister Opse, in the meantime, if you are with us. Okay. Are they hearing us? So, Dr. Maleda, do you have anything to say? Okay, 1 minute, yes.
Okay, እሺ በአማርኛ መናገር እፈልጋለሁኝ። እኔ ያቀረብኩት ጀንደርና ሄልዝ ኬር ነው። Nobody asked me a question and nobody needs to give some comment. So I think is it not you concern or what? Why you are not giving comment? Yeah, so you have to think this one. Or everybody should take a responsibility to involve the women in leadership position. So you have to. Okay, thank you.
It's for the sake of time, as we are running of time. So there's no any comment from our two panelists from online. Thank you to all of our panelists. You made our discussion very lively, lessonful, and I'm sure we have collected a lot. Yes, thank you so much. Can you give them an applause of hand? So, to summarize some very important point, 3 things raised here. 1, collaboration. 2nd, commitment. And the 3rd one is efficiencies. So when we summarize the whole discussion, it goes to these 3 very conceptual points. And very interestingly, these all points are there in Oromia Regional Health Bureau's core values, yes? Core values, if you refer them, yes? So I think it augments, it really supports these values to the region's health system. So I'm very honored to just facilitate or moderate this panel discussion. Thank you. Galatoma Ulfada.
Jirtu.
Dhaabata sirreeffattuu proportional dhaabata keessan gosh
yeroo hojjettanii soggaa takka takka sosochii qaamaa akkanaa godhuun fayyummaa keenyaafis gaariidha. Dhibeelee daddarboon taanes firraa ittisuu dandeenya. Kanaafuu ulfaadha.
Good afternoon, everyone. I hope you have been enjoying the research conference since you're professionals and professionals loves testing, and I think this is to be continued. Now we are going to give certificate to those who are oral presenters, and before that, I would like to invite Mr. Meratu Tarrakin, with the rank of Deputy Bureau Head of the Health Bureau. Please join me to welcome Mr. Meratu to the stage.
Konfiransii Qorannoo Qo'annoo Marsaa 2ffaan yeroo gaarii akka dabarsitan abdii qabna. Miratu garoltajjiitti affeerraa nuuf simadha.
Those of you who will receive this, because will come that way, then you will just go that way. So now I'm going to start calling. Dr. Zalika Amana, please come to the stage.
Dr. Zalika, waraqaa ragaa qophaa'e akka fudhataniif garoltajjiitti yaamna.
Mr. Abdisa Brookso.
Taansun Kabbada Abdisa, walmatti Antonio Soduftan, yeroo keenya wajjin deemuudhaaf. Hamile warri.
Please put your hands together. Mr. Gizacho Abdisa.
Gizacho.
Mr. Iddosa Tesfaye.
Iddosa Tesfaye, Obbo Iddosa Tesfaye.
Tesfaye Bayyana.
Tesfaye Bayyana.
Dr. Ibeltal Sarana.
Dr. Ibeltal.
Mr. Alayu Bogala. Mr. Wakuma Wakena.
Obbo Wakuma Wakena.
Mr. Gashaw Azana.
Obbo Gashaw Azana.
Mr. Getacho Bafakadu.
Obbo Getacho Bafakadu.
Mr. Adisu Natu.
Adisu.
Mr. Yosan Abdisa.
Yosan Abdisa.
Sena Balina.
Hamile male imbaru jecha waan jiran fakkaatu hayyoonni keenya.
Mr. Sena Balina. Dr. Malkamu Brahana.
Dr. Malkamu Brahana.
Dr. Samrawit Sababao.
Dr. Samrawit.
Dr. Gadise Bakala.
Dr. Gadise Bakala.
Mr. Dabasa Gobana.
Obbo Dabasa Gobana.
Dr. Marga Deresa.
Dr. Marga.
Mr. Ashanafi Tadala.
Obbo Ashanafi Tadala.
Dr. Tedros Getacho.
Dr. Tedros Getacho.
Dr. Tamasgan Talaun.
Dr. Tamasgan Talaun.
Mr. Ainacho Sium. Last but not least, Dr. Natsanet Salomon.
Dr. Natsanet.
Now, we are going to give certificate to the moderators. Thank you, sir. Like to your seat. Please welcome Mr. Muratu to his seat. Now, I would like to invite Dr. Tesfaye Kebabo, Deputy Bureau of the Oromiyaa Regional State Health Bureau. Please welcome Dr. Tesfaye to the stage.
Hoogganaa Taanaa Biiroo Fayyaa Oromiyaa, Dr. Tesfaayeen gara waltajjiitti affeerra.
Thank you, sir. Professor Zallaka Makunnan.
Professor Zallaka Makunnan.
Dr. Mugisa Kaba.
Dr. Mirgisa.
Dr. Lamesa Uljura.
Dr. Lamesa Wagjira.
Dr. Zannabu Benya.
Dr. Zannabu Benya.
Dr. Tizita Talaun.
Dr. Tizita Talaun.
Dr. Yadata Dase.
Dr. Yadata.
Dr. Fikadu Asafa.
Dr. Fikadu Asafa.
Dr. Girmay Dinsa.
Dr. Girmay.
Mr. Fork Samru. Professor Selashi Garuma.
Professor Selashi Garuma.
Thank you, sir. Now, welcome, Dr. Tesfaye to his seats. Thank you.
Dr. Tesfaye guddaa galateeffannaa gara dosaantti deebi'uuf simadha.
Now we are going to the panelists. Now, please, I would like to invite Dr. Mengistu Bekkele, His Excellency, the Bureau Head of the Oromia Health Bureau. Please welcome Dr. Mengistu to the stage. Please put your hands together.
Hoogganaa Biiroo Fayyaa Oromiyaa Dr. Mengistu Bekkele paanalistootaaf akka waraqaa ragaa nu kennaniif gara waltajjicha affeerra.
Thank you, sir. Now we are calling Dr. Kabbada Warquu.
Dr. Kabbada Warquu.
Professor Isayas Kabbada.
Professor Isayas Kabbada.
Professor Natsaannat Warqineh.
Professor Natsaannat Warqineh.
Dr. Lijalam Ayyala.
Dr. Lijalam.
Dr. Godana Jarso.
Dr. Godana Jarso.
Dr. Asnaqa Warquu.
Dr. Asnaqa Warquu.
Dr. Malada Tafarra.
Dr. Malada Tafarra.
Please put your hands together. These are those who contributed a lot to this research conference. Dr. Balaina Lata.
Dr. Balaina Lata.
Dr. Solan Bekkele.
Dr. Solan Bekkele.
Sister Obse Taddese.
Sister Obse Taddese.
Dr. Ayyala Tashoma.
Dr. Ayyala Tashoma.
Dr. Abdul Qadir Galgalo.
Dr. Abdul Qadir Galgalo.
Miss Wubishat Damboba.
Wubishat Damboba.
Mr. Wubishat Damboba. Sorry.
Wubishat Damboba.
Lamesa Taddese.
Lamesa Taddese.
Firmai Girma. All right, just thank everyone. Please. Thank you, everyone. Now I would like to invite His Excellency Dr. Mengistu Bekkele to address his keynote speech. Please put your hands together for Dr. Mengistu.
Hedduu galatooma.
Baay'ee galatooma. Ulfaadhaa isiniin jechuun barbaada. Turtiin guyyaa lamaan keenya yeroo keessaniif gumaacha keessaniif maqaa uummata naannoo kanaatiin irra deebi'ee galatoomaa isiniin jechuun barbaada. Keessummaa affeerree isaan cinaatti dhiisuun barbaadu waan ta'eef dhiifama guddaa wajjiniin waan gabaabaa qofa galateeffachuu qofa waan ta'eef waan biraa waan hin qabneef afaan Amaariffaatiin waa muraasa jedhee xumura. Dhiifama naa godha. የዚህ የሁለት ቀን የጥናትና ምርምር አውደ ርዕያችን ዓላማዎች ሶስት ነገሮች ናቸው ለኔ በደንብ ግልጽ ነው ያስኳቸውና ስከታተላቸው የነበረውና ከነዛ አንፃር ስኬታማ ነው ወይስ አይደለም የሚለውን ታዳሚው መገምገም እንዳለበት ነው። እኔ ግን በኔ እይታ የሁለት ቀን ቆይታችን በጣም ስኬታማ የሚያስብሉ ዋና ዋና ጉዳዮችን ብቻ አንስቼ በዚህ ፕሮግራም ስኬት ላይ የተሳተፉትን አመስግኜ መድረኩን እለቃለሁ ማለት ነው። ትላንትና ሙሉ የነበረው ወንበር ቀስ በቀስ ወደ ባዶነት እየተቀየረ ስለሆነ ረጅም ጊዜ ወስጄ ሰው ማሰልቸት ስለማልፈልግ የመጀመሪያው ለመረጃና ለእውቀት መር አሰራር እድል መስጠት ነው። ዋና ዓላማ ያዘጋጀንበት ማለት ነው። ሰው በጣም ብዙ መረጃዎች አሉን፣ በጣም ብዙ ጥናቶች አሉን። ግን የአመራር አቴንሽን ስላላገኘ ወደ መድረክ ስላልመጣ ልፋቶች በየቦታው ተቀብሮ ስለቀሩ እነዚህን እድል እኛም እንፍጠር ብለን በክልል ደረጃ አስበን የተነሳንበት ስለሆነ ሄዶ ይሄ ደግሞ አመራር አሰጣጣችን በእውቀት የተመራ የተገራ መሆን ስላለበት ይሄን ታሳቢ ተደርጎ የተዘጋጀ መድረክ ነውና ከዚህ አንፃር ብዙ ውጤቶችን ብዙ ለስራ ሊውሉ የሚችሉ ጥናቶችን እንዲሁም ለውሳኔ የሚያግዙ የጥናት ውጤቶችን በዚህ መድረክ ላይ ሰምተናል። ሰመሪውን ቢሮ መጨረሻ ላይ በቢሮ ማኔጅመንት አይተን ለታዳሚውም ሼር የምናደርግበትን ፕላትፎርም እንፈልጋለን። በተጨማሪም ደግሞ ለቢሮ ቅድም ጠዋትም ላይ ሲነሳ እንደነበረው እነ ዶክተር አወቀ ሲያነሱ የነበረው ጉዳይ ሲሪየስሊ ኖት አድርገናልና ለውሳኔና ለስራ እናውላለን የሚለውን ነገር ማንሳት ፈልጋለሁ። ስለዚህ በዚህ አንጻር ስመዝነው ጥሩ ስኬት የተገኘበት ነው ለማለት ፈልጋለሁ ማለት ነው። ምናልባት አስተዳደራችን ክልላዊ ነው። ሀሳብን ግን የሚገድበው ነገር ስለሌለ ሀሳባችን ዓለም አቀፋዊ ነበረ ብዬ ለማንሳት ፈልጋለሁ እና ፕሮፌሰር ፒተር በርማን አሜሪካ ቁጭ ብለው እነ ሲስተር ኦፕሴ አሜሪካ ቁጭ ብለው የራሳቸውን እይታ ለዚህ ሀገር ይጠቅማል፣ ለዚህ ክልል ይጠቅማል ያሉትን ማካፈል መቻል እኛ በትንሽ ብንጀምርም ቀስ በቀስ ግን ዓለም አቀፋዊ ይዘትና ተደራሽነት እያገኘ የሄደ ነገር ስለሆነ አስተዳደሩ ክልላዊ ቢሆንም አስተሳሰቡ ዓለም አቀፋዊ የሆነ እንደሆነ ማሳየት ችለናል ብዬ አስባለሁና በጥቂት ጀመርነው እያደገ ወደፊት ከዚህ በላይ እንደሚሳካና እንደሚሰምር በጣም ተስፋ አደርጋለሁ። ሁለተኛው ዓላማችን በዚህ ስራ ላይ ምንም ጥቅም በግል ደረጃ የሚመዘን ነገር ሳያገኙ እድሜያቸው ሙሉ ለዚህ ስራ መስዋዕትነት ከፍለው የሰሩ ሲኒየር ባለሙያዎች ኢትስ ኤ ታይም ቱ ፔይ ባክ ለኔ ማለት ነው እንደሚሰማኝ ብዙ ከነሱ የሚማሩ አካላት ስላሉ እድል አግኝተው አዲሱ ትውልድ ከነሱ እንዲማር እድል ፈጥረናል ብዬ አስባለሁ። በጣም ብዙ ፕሮፌሰሮች የሚሄዱበት አላጡም፣ የሚሰሩት አላጡም። ብዙ የሚሰሯቸው ኮምፒቲንግ ፕራዮሪቲዎች ያሏቸው እዚህ መጥተው ለአዲሱ እና ለአመራራችንም ጊዜያቸውን መስዋዕት አድርገው ማካፈል ያለባቸውን እውቀት ያካፈሉበት ስለሆነ በዚህም መስፈርት ስመዝነው ስኬታማ ነበር ብዬ መውሰድ እችላለሁ ማለት ነው። ሶስተኛው ለአዲስ ሪሰርቸሮች የሞቲቬሽን መድረክ አድርጌ ነው ያየሁት ማለት ነው። አንደኛ ራሳቸው የሰሩትን ስራ በድፍረት ወደ መድረክ አውጥተው እንዲያቀርቡ እድል ፈጥረናል። ሁለተኛ እነሱ የሰሯቸው ስራዎች እነሱ በሚሰሩበት አካባቢ ደግሞ ወደ ተግባርና ወደ ውሳኔ እንዲቀየሩ የኛ ማኔጅመንት ሙሉ በሙሉ ከታች ጀምሮ በዚህ አዳራሽ ውስጥ ተሰብስቦ ነው ያለውና እኛ ብቻ ቢሮ የምንመራ ሰዎች ብቻ ሳይሆን በየደረጃ ያለው አመራር የተገኘበት መድረክ ስለሆነ እዚህ በየደረጃ የተሰሩ ጥናቶች ወደ ውሳኔና ወደ ተግባር የሚቀየሩበት እድል የፈጠረ መድረክ ስለሆነ በዚህኛውም እይታ ሳየው ስኬታማ መድረክ ነበር ብዬ መውሰድ እችላለሁ ማለት ነው። ሌላ በጣም ከስር አስምሬ ማንሳት የምፈልገው ነገር አንዳንዶቹ እዚህ ሲነሱ የነበሩ ነገሮች ቢሮና ታዳሚዎቻችን በቅርበት የምንነጋገርበት መድረክ አለመኖሩ ነው እንጂ ቢሮ የጀመራቸው ከዛም ዘለግ ብሎ የተጓዛቸው አንዳንድ ስራዎች እንዳሉ ማንሳት ፈልጋለሁ። ለምሳሌ ዶክተር ጎዳና የፕራይቬት ፐብሊክ ሚክስ እና ፓርትነርሺፕ በሚል ቅድም ሲያነሳቸው የነበሩ ነገሮች እኛ በዚህ መድረክ እድሌን ተጠቅሜ ማንሳት የምፈልገው ፕራይቬቶች ራሳቸውን እንዲሆኑና ስራቸውን እንዲሰሩ ብቻ ሳይሆን መንግስት አግዞ ከተቻለም አብሮ ኮፋይናንስ አድርጎ ካልተቻለም የመንግስት ተቋማትን ፓርሻሊ አሳልፎ ለነሱ በመስጠት የተሻለ አገልግሎት ለህብረተሰቡ መስጠት የምንችልበትን ሁኔታ በክልል ደረጃ በክልል ካቢኔ ጭምር ተስማምተንበት አንድ ሁለት ቦታ ጀምረናል። በትልልቅ ከተማዎች ላይ ያሰፋን እንሄዳለን ማለት ነው። ስለዚህ ዶክተር ጎዳናና መሰሎቹ ብርቱ ከሆኑ ወደፊት ከመንግስት ሌላ ግንባታ መገንባት አያስፈልጋቸው ፓርሻሊ የራሳችንን ግንባታ ተጠቅሞ ፕራይቬት ፕራክቲስ እዛው መስራት የሚችሉበትን ሁኔታ በአሰራር ደረጃ ዘርግተናል። ይሄ በጣም ጥሩ ነገር ነው ብዬ አስባለሁ። ምናልባት በሌላ አጠራሩ ክሊኒካል ሰርቪስ አውትሶርሲንግ ማለት ነው። የክሊኒካል ሰርቪስ አውትሶርሲንግ ጽዳት፣ ምግብ ምናምን ብቻ ሳይሆን ክሊኒካሊ አሁን እኛ ይሄ ምርመራ የለም ውጭ አሰርተና ይሄ ችግር አለ እንደዚህ አድርገና ምናምን የምንላቸውን ታካሚው ላይ ምልልስ ከምናበዛ ፕሮቫይደሩ ወደ እኛ ተቋማት የማቅረብ ስራ በህግ ደረጃ ተቀብለን እየሰራንበት ነው። በሚኒስትሪ ደረጃ ጥረቶች አሉ። ግን እኛ እንደ ክልል ህግ የማውጣት ስልጣንም ስላለን በዚህ ደረጃ ሄደንበታልና አንድ ይሄንን ነገር ማንሳት ፈልጌ ነው። በትንሹ ታንት የጀመርናቸው የዚህ የሙያ ማህበራት ትብብር በኋላ ላይ እናያለን እንዴት ተግባራዊ እንደምናደርግ። በዘንድሮ ዓመት ከአንድ መንግስታዊ ያልሆነ ድርጅት ትልቅ ገንዘብ አግኝተናል፣ በድጋፍ ደረጃ ማለት ነው። ያንን ከመንግስታዊ ያልሆነ ድርጅት ያገኘነውን ገንዘብ ፉሊ እኛ ብቻ ኢምፕሊመንት እናደርገው ሳይሆን የሙያ ማህበራት ከኛ ተጋርተው በዚህ ስራ አተግባበርም ላይ እንዲያግዙንም ራሳቸው ደግሞ እንዲጠናከሩ እንዲሰሩ ፍላጎትም ስላለን በራሳችን ፕሮፖዛል ውስጥ አስገብተናል። ሙያ ማህበሩ ብዙም በዚህ ውስጥ አልተካተተም፣ ግን ሞር ወደ ኦፕሬሽናል ኢምፕሊሜንቴሽኑ ስንገባ እነሱን እያሳተፍን የምንሄድ መሆኑን መግለጽ ፈልጋለሁ። ከዚህ በዘለለ አዮፓ የሚባለው ኢንተርናሽናል ኦሮሞ ሄልዝ ፕሮፌሽናል አሶሲዬሽን የሚባለው ሲስተር ኦብሴ የተወከለችበት ዛሬ ማለት ነው። እነ ዶክተር ኑረዲን ነበሩ፣ እነ ዶክተር ሌላ አዲስ የሊደርሺፕ ለውጦች አሉ፣ ኢብራሂም አሜ አሁን የተቀበሉት ማለት ነው። በዘንድሮ ዓመት ከነሱ ጋር ባለን ፓርትነርሺፕ 50 ሚሊዮን ዩኤስዲ ወርዝ የሚያደርግ ሜዲካል ኢኩፕመንት ትራንስፖርት ማድረግ ጀምሯል። ወደ 8 ኮንቴነር አሁን ወደ ሀገር ውስጥ ገብተዋል። ሌሎች ቀሪዎቹ የሜዲካል ኢኩፕመንቶች እንደዚሁ በስራ አጋጣሚ ያገኘናቸው ትረስትድ ፓርትነሮች ወይም የሙያ ማህበራት ወደ ተጨባጭ ስራ የገቡበትም ስለሆነ እዚህ መድረክ ላይ የምናነሳቸው ነገሮች በደንብ ተጠናክሮ መሄድ እንዳለባቸው ሆኖ ግን ቢሮ በሙሉ ፈቃደኝነትና በሩን ክፍት በማድረግ እነዚህን አካላት ለመቀበልና አብሮ ለመስራት ዝግጁ መሆኑን ማንሳት ፈልጋለሁ። ለምንድን ነው ይሄን የማነሳው? ብዙ የሚነሱ ነገሮች የቢሮ ፍቃድ ከሆነ ቢሮ ካሰበበት ቢሮ ከሰራ እየተባለ የሚነሱ አስተያየቶች ስሰማ ስለነበረ ቢሮ የናንተ ነው፣ ቢሮ የናንተ ነው። ምንም አይነት ጥርጣሬ ሳይኖር በጋራ ተቀራርበን መስራት ከቻልን ብዙ ለውጥ ማምጣት እንችላለን ለማለት ፈልጌ ነው። በዚህ የተጀመሩ ነገሮች እንዲቀጥሉ ጥሪ ለማቅረብ ፈልጌ ነው ማለት ነው። መጨረሻ ላይ ማንሳት የምፈልገው ተመሳሳይ ነገር መላልሶ ማድረግ ጊዜውም አይፈቅድም፣ አስተሳሰቡም የሞኝነት ነው። ስለዚህ ትናንትናም በመክፈቻ ንግግሬ ላይ ፈጠራና ፍጥነት የሚለው ነገር ምናልባት የኛ አሁን ነባራዊ ሁኔታችንን ታሳቢ ያደረገ ኢኒሼቲቭ የሚመስለኝና በፈጠራ ካልታገዘ ፊት ለፊታችን ያሉ ችግሮች እየተወሳሰቡ እንጂ እየቀለሉ አይሄዱም። ስለዚህ ያለ ጥናት ደግሞ ሴክተሩን ለመምራት መሞከር ጠዋት ላይ ዶክተር አየለ ሲያቀርብ የነበረው የኢኖቬሽን እና የቴክኖሎጂ ጉዳይ ሳንወድ በጥናትና ምርምር ስራዎቻችን እንዲታገዙ የሚያስገድዱን ነገር ስለሆነ በጨለማ ቤት ውስጥ የሆነ የጠፋን ዕቃ እንደመፈለግ ነው የሚመስለኝ ለኔ ማለት ነው። ያለ ጥናትና ያለ ምርምር ያለ ሙያዊ ድጋፍ ሴክተሩን ለመምራት እንትን መሞከርና ከዚህ በመነሳት ምናልባት የሚቀጥለውን አመት የጥናትና ምርምር አውደ ርዕያችን ሞር ወደ ኦፕሬሽናል ሪሰርች እንዲያተኩር ትላንትና ማታ ላይ የራት ግብዣ አድርገን ከተወሰኑ ከፍተኛ ባለሙያዎች ጋር ውይይት ስናደርግ ነበርና የአካዳሚያውን እንትን ሪፕሊካ መሆን የለበትም፣ የዛ ድግግሞሽ መሆን የለበትም። ሞር በተጨባጭ እኛ ከምንሰራቸው ስራዎች አንፃር እያጋጠሙን ያሉ ችግሮችን ቀድመን ለይተን በሱ ላይ ጥናቶች እንዲሰሩልን አድርገን እነሱ ወደዚህ መድረክ ብናመጣ የተሻለ ይሆናል የሚል አስተያየት ስለተሰጠን ይሄንኛው በጣም ክሪቲካል ኮመንት ነው ብዬ ስለምወስድ የሚቀጥለው ዓመት ላይ እዚህ የተገኛችሁ ሪሰርቸሮች በዚህ ሁኔታ ራሳችሁን ቃኝታችሁ ትመጣላችሁ ብዬ አስባለሁ። ቢሮም ከዩኒቨርሲቲዎች ጋር በመሆን ኮፋይናንስ አድርጎ ከዚህ የተሻለ ሪሰርቾች ተሰርቶ እንዲሁም ደግሞ ሪሰርቸሮች ተበረታተው የተሻለ መድረክ እናዘጋጃለን የሚል እምነት አለኝ። በአጠቃላይ የተገኙ ስኬቶች ብዙ ጊዜ ችግሮቻችንን ስለምንናገር ነው እንጂ ችግሮቻችንን ብዙ ስለሆኑ ነው እንጂ የተገኙ ስኬቶች ሊበረታቱ ልንደሰትባቸው የሚገቡ ነገሮች ስለሆነ እኔ መጨረሻ ሜሴጅ ምንድነው ላጋጠሙን ችግሮች ለሚገጥሙንም ችግሮች ብቸኛው መፍትሄ ቅንጅትና ትብብር ብቻ ነው። ይሄንን ለማድረግ ደግሞ የሚችልና ፈቃደኛ የሆነ የቢሮ ማኔጅመንት አለ። ይሄንን ለመደገፍ ቁርጠኛ የሆኑ መንግስታዊ ያልሆኑ ድርጅቶች ከኛ ጋር አሉ። ጤና ሚኒስቴርም በዚህ በኩል የራሱን ድርሻ ይወጣል ብዬ አምናለሁ። አንዳንድ የተነሱ ጉዳዮች እውነትም አሳማኝ ናቸው። እነሱን ወስደን ወደ ስራ እንተገብራለን። በዚህ ቤት ውስጥ ውር የሚሉ ጥቂት እንስቶች ናቸው፣ ሴቶች ናቸው። ስለዚህ ይሄንንም ቀይረን ቢሮ የራሳችን ኢኒሼቲቭ ሴቶችን ወደ አመራር ቦታ የማምጣቱንም ስራ የሚቀጥለው ዓመት ቢያንስ በመክፈቻ ንግግሬ ውስጥ አካትቼ አቀርባለሁ ለማለት ነው። እነ ዶክተር ቅድም የተነሳው ነገር ትክክለኛ ነው። 70% ሰርቪስ ፕሮቫይደሩ ሴቶች ሆነው ግን ቤት ውስጥ የእንስት ቁጥር ለማየት የሚያስቸግርበት አዳራሽ መልሰን አናይዬ ተስፋ አረጋለሁ። በመጨረሻ ለዚህ ጥናታዊና ጥናትና ምርምር አውደሪ ስኬታማ እንዲሆን ድርሻችሁን ለተወጣችሁ ላስተባበራችሁ በመጀመሪያ ከራስ መጀመር በጣም ጥሩ ስለሆነ የቢሮ ሰራተኞች፣ የክፍሉ ኃላፊዎች እንዲሁም በሁለቱ ቀን ስታስተባብሩ የነበራችሁ በሚያምር መልኩ ባህላዊ ልብስ ለብሳችሁ ሲሰሩ የነበራችሁ የቢሮ ሰራተኞችና ማኔጅመንት አባላት ማመስገን እንፈልጋለሁ ማለት ነው። በዚህ አጋጣሚ ማንሳት እንፈልገው ይሄ ፕሮግራም ሲዘጋጅ እርዳታ ላይ ብዙ እንዲንጠለጠል ስላልፈለግን በቢሮ ማኔጅመንት ፋይናንስ የተደረገ ነው። ቢሆንም ግን ይህንን ደግሞ ስራ በማገዝ በኩል የፍኖት ሃርቫርድ ቡድን እንዲሁም አመራሮች ይሄ ስራ እንዲሳካ ላደረጋችሁት ድጋፍ በቢሮ ማኔጅመንት ስር ድጋሜ ማመስገን እፈልጋለሁ። የኢትዮጵያ ፐብሊክ ሄልዝ ኢንስቲትዩት፣ የኮዴድ፣ የዲዩፒ፣ የካርተር ሴንተር፣ ኬር ኢትዮጵያና ኬርላንድ ሆስፒታል ለዚህ ፕሮግራም ስኬት ላደረጋችሁልን ድጋፍ ኬርላንድ ሆስፒታል አዲስ ሆስፒታል ነው። ወደ ፕራይቬት ፕራክቲስ እየተቀላቀለ ያለ በቅርብ ጊዜ በይፋ ፕሮግራሙን ያስጀምራል ያስመርቃል ብዬ አስባለሁ። እንደዚህ አይነት ተቋማት በዚሁ አጋጣሚ ስራ በመጀመራቸው ቢሮ ደስተኛና ድጋፍም ሲያደርግ እንደነበረ በማሰብ ለዚህ ፕሮግራም መሳካት ደግሞ ላረጋችሁት ተሳትፎ ከልብ እናመሰግናለን። ከሁሉ በላይ 2 ቀን ሙሉ በተለይ ደግሞ ዛሬ የእረፍት ቀን ነው። አብዛኛው ሰው ከሰኞ እስከ አርብ ትንስ የሆነ ቀን እንደሚያሳልፍ እናውቃለን። ዛሬንም ጭምር በከፍተኛ ዲሲፕሊን በመታገዝ ፕሮግራማችን እንዲሳካ ላደረጋችሁ ተሳታፊዎች፣ አስተባባሪዎች፣ አወያዮች፣ አቅራቢዎች በኦሮሚያ ጤና ቢሮ ስም ማመስገን እፈልጋለሁ። ከሁሉ በላይ ደግሞ የሚዲያ አካላት ላይቭ በማስተላለፍ ጭምር ይሄ ፕሮግራም እንዲሳካ ስላደረጋችሁ ከልብ ማመስገን እፈልጋለሁ። የሚቀጥለው ዓመት ሰው ይበለን። መልካም አዲስ ዓመት። አመሰግናለሁ።
ዶክ አስመናቱርት ዶክ ዲፈማዎች አስናቱሪ አልተኩ ዲፈማዎች አንዳንዴ በተራ ደስ ስተት ይፈጠራል። ስለዚህ ለተፈጠረው ስተት በጣም ይቅርታ እየጠየቅኩኝ አንድ ባለሙያ ረስተናል። ፕሮፌሰር ዘውዴ ብርሃኑ ባካችሁ ሞቅ ያለ ጭብጨባ ስጡልኝ ባካችሁ። ዶክተር መንግስቱ ከኢዶ ሳኒ ጋር ነው ሲመጣ ያደቺ ሰው ኮን ቀባ